Ladies and gentlemen, welcome to the Lake Superior Quality Innovation Network, a toolbox with Hinges, innovative strategies to avoid readmission to inpatient setting webinar. Your host today is Carla James. Please go ahead.
Thank you. Good afternoon, everyone. Again, my name is Carla James. I am a clinical quality consultant at Impro. For those who are unfamiliar with Impro, we are a healthcare quality improvement organization who work on several different healthcare initiatives. And today, our focus is our behavioral health project, which consists of two components. The first being working with practices to increase alcohol and depression screening. And the second component, which is why we are here today, is working with inpatient site facilities to reduce all-cause readmissions. And today we actually have a inpatient facility that we work with who we have recruited who are doing some good things with their patients, and we thought that we would showcase what they're doing over there. And today we have Andrew Rhodes, who will be presenting on a toolbox with Hinges. So I want to thank him for his time in putting this presentation together. And Andrew, you may have the floor.
Thank you so much, Carla. Like we said, our title is a toolbox with Hinges, and we're going to kind of run through what we do here in Detroit at Stonecrest Center. But I'm actually going to pass it to my director, who's going to begin the presentation, Paul Anderson.
Hello, I'm Paul Anderson. I'm the Director of Clinical Services, and thank you so much for having us on. We are delighted and very happy to be able to share with you how to optimize care, or how we optimize care and reduce recidivism rates. We'll go through the objectives. There will be three presenters in all. I'll be myself, Andrew Rhodes, who is the social work supervisor, as well as Jared Olafson, who is the manager of utilization management. We can put the slide to objectives. And as always, special thanks to Ms. James. Thank you for bringing this together and bringing the regional states together and talk about the important issue of recidivism rate. Some of the objectives that we're going to touch on is the introduction of our very own case management model. It is a model that will be discussed a little bit later, but it's more specific to the clinical end of our segment. We also want to talk about building relationships with appropriate resources. Discharge planning, we're only as strong as the community that we involve ourselves in. We want to talk a little bit about how a BCBA, a board-certified behavior analyst, that consulting and passing forward to caregivers and support systems to help change the home environment. And the fourth one, which is not on here, that we just added in the last 5 minutes, is some auditing measures, and that's what Jared Olafson, our manager at UM, will discuss about as well. We are an informal group. Between slides, if anyone want to ask questions or clarification, we don't mind. Please feel free to do so. Towards the end of the presentation, we will talk a little bit about a success story that we recently had, and of course, then we'll hold some time for applause. Our Stonecrest Center, we just talk a little bit about who we are, what our demographics are, what do we do. We're much like your facility, a lot of similarities and possibly some differences. We are nestled in the always sunny northeast Detroit. We have a metropolitan area of about 4.3 million people. That is the 13th largest metropolitan statistical area in the United States. We are a mostly urban setting. We are one of 6 IMDs, meaning that we do not have a medical center attached to our facility. We have approximately 12 other psychiatric hospitals that do have the support of an emergency room. We do have specialized units. We do have a unit just for developmental disabilities, adult unit with psychosis, adult unit with affective disorders, an adolescent unit, an older adult / geriatric unit, and adults with that needs a little bit more additional staffing. We call it our acute unit. We are a very large hospital. We are 125 beds as of today. Tomorrow will be 134. We average about 312 admissions a month. We do have 80% of our clientele are from the Tri-County area. Tri-County is Oakland, Macomb, and Wayne counties. 20% of our other population resides outside of these counties, and we do admit from all over the state of Michigan. Our admissions process, 98% of our admissions come from an emergency room. They come from another hospital. The hospital contacts us and submits a clinical packet to our admissions team. In return, our admissions reviews the packet. If there's any medical or if there's something, a question that it may be outside of our scope of practice in regards to medical, we do contact our director of nursing and or our CNO to come down to admissions and review the packet. Most of our admissions team is comprised of social workers and counselors. We talked about a little bit about our medical, the scope. The next slide illustrates the medical criteria at the Conquest Center. Again, we do not have medical backup or an ER. We collaborate with 2 local ERs in the area for any patients that are already admitted and needs to be sent out. If the patient is sent out and not admitted, for year to date, we re-admit 100% of our patients. If they are admitted, our statistical analysis states that we have admitted 88% of the patients within 72 hours if they are admitted to a medical scope hospital. The other 12% of patients were deemed as outside of our medical scope. We average about 68 intakes are deflected per month, not average over the year, but per month were denied based on this criteria. I won't read through them. I'm sure that we do not accept patients on the DNR, trachs, pregnancy, transplant, catheters, and so on. So to be transparent, these are the patients that we do have difficulty admitting to our particular hospital. So population served is, again, I mentioned we're a 125-bed hospital. We are 120.2 ADC year to date. 25% or 1 of 5 patients are Medicare, straight Medicare. 15% are a My Health Link or a managed Medicare. The My Health Link, that might be something new to Michigan, of course. That is a dual Medicare Medicaid pilot program. That is coordinated by our prepaid inpatient health plans. There are 4 of them in the state of Michigan, and they're responsible for managing patients that are dual eligible. So 15% of our population are comprised of the My Health Link patients. 50% Medicaid and 15% commercial insurance. Our average length of stay overall as a hospital is 11.3. We do host quite a few patients that are waiting for a long-term setting, but our average length of stay as we drill down for Medicare patients is just shy of 15 days, 14.8 to be exact. Our ADC for Medicare is 30 patients, or as mentioned earlier, 25% of our population. Just ran through some of the demographics of the hospital and give you an idea of what type of challenges that we incur. But we want to talk about how we came up with our title, Toolbox with Hinges. Everyone has a toolbox in their hospital where they have discharge planners. Everyone has person-centered plans, their clinical groups, their go-to step-down facilities, med management, treatment team, dietary, as well as physician reviews. But some things that we have to think outside the box to be able to address recidivism rate, especially with our Medicare and elderly population, that Suncrest has come up with some unconventional ideas. Some of them being a special way how to coordinate with outpatient teams, the introduction of a board-certified behavior analyst, again, mentioned before in our objectives, the case management model, and the specialization of clinical staff. We feel that optimizing treatment while the patients are here, involving the outpatient providers, the support coordinators, the case managers, the patient's guardian support systems, bring in the appropriate discharge planning is all recipes for success. And we'll drill down and get more, we'll drill down a little bit more and get have a little bit more examples for you. I'll turn it over to our social work supervisor, Andrew Roach, and he'll discuss our team as well as our management case management model. Andrew?
So our team, kind of the highlights that we wanted to focus on. I mean, most inpatient facilities will have a multidisciplinary team, but some things that set us apart, at least we feel do, is that our medical director is also specialized in geriatric psychiatry. He works in the community as well. We have an internist on board. We have a specialized geriatric psychiatrist on the unit itself. We use dietary consults, psychological testing. Of course, our nursing department is vital. Our activity department actually encompasses 3 specific disciplines. We have art therapy, music therapy, and recreation therapy. We utilize these 3 disciplines to reach out to our specialized populations in specific ways. Some are more effective with the specific populations that we serve. We, of course, have our social services department, which encompasses counseling and social work disciplines, and then our BCBA, as we've spoken about multiple times. So leading from that, we're going to discuss the case management model. This is something that we've been using here for several years. It was actually brought on board by Paul Anderson when he came to the facility. It's a unique way of looking at the role of the social services department within the inpatient setting. Traditionally, the role between UR and social services are split. There are 2 separate staff functioning over the same caseload. In our facility specifically, this is encompassed under one individual. So a social worker or a counselor, or as the official title here is clinical therapist, will have a caseload of roughly 10 patients and manage not only their treatment and discharge planning, treatment team, communicating with the doctor, but they will also communicate with the funding agencies. We found this to be highly successful. Our denial rate is very low. It's something that we're able to advocate for more treatment for our patients. We have a better understanding, and it's just a holistic view on the patient. We understand the whole case top to bottom. And that's kind of the snapshot of the model. The dual role is encompassed under one staff person. Additionally, in regards to that model, we encourage expertise and mastery for the populations with our staff. So we assign staff to a population they feel effective with. We send them out to conferences and trainings. We do in-services here specific to populations. We encourage them to reach out to agencies and other resources within the community to visit their sites, to speak with them about effective strategies, and we incorporate them into the treatment here. Beyond that, it's things that our staff seek out themselves, and we're always looking at improving the process. We've also worked with our universities in the area to look at our processes as well as our group and find effective strategies, which we'll touch on a little bit later. I am going to pass it along to Jared, our UM supervisor, to speak in regards to our Medicare audit.
Yes, hello. We got on the next slide. These are Medicare audits. We complete the required documentation and admission medical necessity at the third day for every admission to make sure that they're appropriate, that they do have, psychiatric diagnoses that have a reasonable chance of improving, that we're, addressing and, being aware of all the different histories and that could contribute to a patient's success afterwards, and that there's a preliminary discharge plan right in the beginning, from that first couple of days, we know what the goal is and where people are going. And the portion after that we do weekly, and I do those myself to kind of come around and take a look and make sure that our, get a second pair of eyes on the case and make sure that we're, communicating with as many support agencies and families as we can be, and that the treatment's being effective. And we tabulate all these audits into a larger spreadsheet that then kind of gives us what our percentages are, where we might have some deficiencies. We just use those for anything that's below 90, but really, just anywhere that has any errors, it's worth taking a look at, what kind of situations happened or what can we look to improve as we go forward, and that's proven to be pretty helpful in keeping that all together. Go for it.
So in regard to discharge planning, our clinicians work closely with a lot of different agencies. The majority of our Medicare patients are on our geriatric unit, but they also are on some of our adult units with the MI HealthLink plan, as well as early disability. But in regard to our geriatric population, we work with A Place for Mom, which is a network of home for the aged, nursing homes, assisted living. We also work with Medilodge and Sava, as well as several home health care agencies that can provide in-home psychiatric nursing or care for that transition back to the home with a family member, maybe even a temporary placement so that we can pursue, or the family can even pursue, a longer-term placement for an individual of higher need. We work with other networks, of course. We have a person that we've been working with for several years. She's a group home or home for the aged, or even semi-independent living liaison. She works with a network of providers, and we can call her in a pinch, in all honesty, and she will reach out to all of her providers, given a brief history on the patient, and find a suitable placement, work with guardians, work with the patient themselves, set up an interview while they're in our facility to aid in that transition, so that we're not keeping someone beyond what they need here. We're looking for active placement, like Jared spoke to. We want to begin early and look for that appropriate placement as soon as possible. We also partner very closely with Neighborhood Services Organization, who completes a screening in regards to individuals' appropriateness for placement in a skilled nursing setting. Anyone coming from or going to a skilled nursing setting needs to be screened through NSO. So that's a very important partnership. A level of care that we've been accessing, I'd say over the past 2 years, that's been very helpful is respite care. Nursing facilities in our area have come up with this level of care, in all honesty, to help transition from the home or from a psychiatric facility. It's a 30-day stay where the individual is within the facility of the skilled nursing, but they not necessarily are a patient. It's to see if they would function well, to help with step down from our inpatient psych unit. It's it's a very new thing, but it works very well in regards to some barriers that we come across with return to the home or appropriate placement in the home or working with protective services and an inability to return to a home. We also provide transportation for our patients. This is something that's unique to our facility as far as we know. We partner with an EMS provider to provide non-emergent transport for our patients back to their home anywhere within the state of Michigan. And this is to ensure for us we have that continuity. We know the person is getting where they need to go. We're not sending them on a bus necessarily or setting up a taxi or wishing them well as we walk them out the front door. We're wanting them to get to that next level of care, to that safe placement, so that we can be sure that we've done everything we can to ensure their stability going forward. And in regard to that, we work very closely, like Paul spoke to, with support systems, with home environments. We also work in regards to outpatient teams to help transition the person, accelerate a level of care possibly from maybe an outpatient to a partial setting, or an ACT team, assertive community treatment, where a clinician or a team of clinicians will be out to the home multiple times a week. It's something that we try to smooth that process because, like we spoke about at the beginning, this is about recidivism. So we're looking to set up that safety net on the outside so they don't return to our setting. With that, I will transition back to Paul to speak about our BCBA.
Thank you. So just talking about the highlights, just to recap a little bit, we are building the relationships with resources. I know a place for mom was talked about. I know that the common phrase that we hear all throughout the United States is that you probably heard of a place for mom. It's not only just contacting them once in a while, it's having them come out to your facility on a routine basis, getting to know that company very well, getting to know your nursing homes in the area, and having them come to your facility or going there and routinely, whether it be monthly or every other month. It's important for the social services arena, in regards to the case management model, is to be in contact with the physician each day, be in contact with resources and support systems each day, understanding specialized trainings for the older adult recipients. That is crucial. We did talk about transportation, and yes, you heard it right. We do provide transportation throughout the state of Michigan, whether it's 20 miles away or 450 miles away. We front the cost. We pay for it. Of course, we ask for the support systems if they would like to pick up their loved ones. If by any chance they cannot, we do provide that service throughout the state of Michigan. Moving forward to the next slide, we're talking about treatment. This is the one I'm really excited about, is the how to engage a board-certified behavior analyst. I don't know about other states, but here in Michigan, it is very difficult to employ a BCBA. They're generally recruited right from college, right from the university. It is in high demand here in Michigan. We were lucky enough to have a BCBA, and along with that, we do have a collaborative relationship with Eastern Michigan University for their psychology and ABA program. So we do have 3 interns from the university as well as being part of the behavioral team. The board certified behavior analyst is consulted that's paid off. The physician, as well as an RN, can start a consult for a BCBA. Generally, that's done when a person is on a one-to-one, whether it's for behavior or for a fall risk, sexually acting out, or also if the person is in restraint or physically managed, 2 or more times, or as needed. Especially with their developmental disability population. It starts off with the behavioralist conducting a functional assessment interview with the patient and their support systems. In return, she consults with the physician, talks about the antecedent, the behavior, consequences. She defines the one-to-one, the patient expectations, what trainings that she would provide to the staff, and then be able to provide those types of trainings. Once the physician signs off on the plan, the behavioralist completes a functional behavioral plan along with the treatment team, and then starts her trainings for our mental health associates, our nursing staff, our social services, our counseling, as well as anybody else that is on that unit, and that includes janitorial staff as well. Any staff that is in contact with our patients. We also evaluate, of course, as needed. It's generally weekly, but we do evaluate the program, the plan, several times a week. The important piece of this is that upon discharge, the behavioralist also educates the next level of care on the behavioral care plan. So she will sit down with the family. She'll sit down with the group home or the nursing home, and share the behavioral plans and share the expectation and the experiences that we have here to our facility, and make sure that all questions are answered and responded to. So there's a continuity between Soul Care Center and the next level of care, especially for individuals who need that extra support. And we'll talk a little bit about that in our success story as well and what that looks like. Then we'll move on to our actual types of therapy for patients that are older adults, which would be called reminiscence therapy. Sir?
Yes. So part of that treatment, like Paul touched on, as a behaviorist, but we've also, like I spoke about earlier, partnered with the universities in Detroit in regards to examining our process and helping us find effective strategies. And one that kind of rose to the top in regards to our older adult population was reminiscence therapy. This reminiscence therapy is defined as the process of recalling personal experiences from an individual's past that will help in the individual's function would be improved by increasing demands on their impaired cognitive abilities, and also capitalizing on their preserved ones. So we're in reminiscence therapy. The clinicians are working with our patients on the geriatric unit in regards to past successful strategies, past successful experiences, and trying to carry those strategies, those feelings, those memories of higher functioning, more successful, more expressive times forward to the present. It's a fascinating experience. The patients begin, and it seems like a almost casual sharing experience of memories, and by the end of the session, the patients feel emboldened, and they can kind of reckon back to those times where they were able to manage their mental illness or their frustrations or their anger more effectively, and you can see a marked improvement in how they manage themselves on the unit. It's something that our therapists use on a daily basis in one-on-one interactions with our clients, as well as making sure it's part of our group treatment at least weekly. It's something that I would encourage you all to look into if you have a significant geriatric population. So they use this treatment and many other, like we spoke about the activity therapy department with their music therapy and art therapy and recreation therapy to help our Medicare population deal with, of course, mental health, as we are a freestanding mental health facility, grief and loss, seeking out social supports, issues of abandonment, and of course with our older population, loss of agency, to mention Alzheimer's as a secondary diagnosis to a primary mental health issue, other cognitive deficits, and then of course early disability for some of our SPMI adult population. And I guess that leads right into our success story with Paul.
Well, just recently we had a story. I was thinking that it would be helpful just to wrap everything up and identify a story that we had that kind of touched all bases that we talked about. We had a 32-year-old Medicare recipient that was on a 2-to-1 in a med psych unit across town. She was there for over 30 days waiting for long-term placement. She spent most of her day in restraint or in isolation as she was extremely aggressive towards herself as well as others. She would scratch up her face, try to get at her eyes. She would scratch over people. She was extremely aggressive. She was, her mother, heard about our ABA program, as well as the PIHP, which is really the insurance company here in Wayne County. And they recommended a transfer at this med psych over to Stonecrest Center. And of course, we were a little bit hesitant, but we had our treatment team go out to the new med psych facility and interview Katie. She was in 4-point restraint. She had cuts all over her face, all over her arms, and we decided that we will take on the challenge and we will transport her to our facility. And because we have the ability to be able to provide the ABA, the behavioralist type of setting, and see if we can find or we can have a marked improvement with the individual. That same day, she was transported to Stonecrest Center, where she stayed an additional 45 days. In the meantime, we did have an immediate behavioralist consult. And one thing to note that Katie, she was mute. She did not talk. And at one point, she was able to talk, but she hadn't talked in many days. So we started the behavior plan right now to focus on language barriers and using the Texas system. Our behaviorist went through each discipline and their expectations and how to interact and how to deal with, understand Katie's antecedents, her behaviors, and what to do and how to respond, exactly what to say, set up a routine. We had both our behavioralists as well as our CTRS, which is a recreation therapist, provide all the education and training for our staff around the clock. So we staggered their hours. It was rough for the first 4 or 5 days, absolutely. But when we started getting more on the routine and started to follow through with the behavioral management plan, while she was waiting for long-term, the long-term was soon to be revoked, because when we were meeting with the treatment teams and we were meeting with the PIHP, her behaviors no longer warranted a long-term facility, and the doctor wrote the order for Katie to go to a semi-independent living with staff around the clock. That was a huge turn of events, as she was all set to go to long-term. We were able to locate and identify a semi-independent living with people with 24-hour CLS services. But the kicker is that we had our behavioralists as well as our CTRS not only engage and not only go over there and talk and go over the plans with the group home, they stayed there for 30 days. I know I don't expect every facility to do that, but we were able to lease out our CTRS and our behavioralists for 30 days to be there with the staff, to be there with Katie. They staggered their hours anywhere from 7 a.m. to 9 p.m. and show the staff step by step of how to be able to engage and address Katie's behaviors. She was able to stay out and remain out of a long-term facility as well as acute inpatient facility. And she was discharged from here in April. So it's been a little over 70 days now in county. that she is able to remain in the least restrictive environment in a little house in Livonia, Michigan. So that is our success story. I know that's a little bit over and beyond or outside the scope of most places, but that is something that we did not see coming, but we were able to think a little bit outside the box, and that's why we have a toolbox with hinges. And sometimes you have to go outside the traditional rule to be able to maintain our patients' satisfaction and safety. At this time, that concludes our presentation, and if we have any questions, of course, we would love to entertain them.
Ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your touch-tone telephone. Again, if you have a question at this time, please press the number 1 key on your touch-tone telephone. Again, ladies and gentlemen, at this time, if you have a question, please press the number 1 key on your phone. Okay, it looks like we do not have any callers in queue for questions.
Well, this is Barb at MPRO, and as I was listening to your wonderful presentation, I really appreciated that. I was just wondering how you talked about how you collaborated and you have the social workers doing the utilization review. Did you have to sort of convince the administration to combine those two roles under the social work department, or could you give a little background on how you came about that realization and how it was sort of approved to Congress?
Yeah, thank you for that question. I love when someone asks me that question.
Oh, well, there you go.
I was actually employed at, I was working with insurance managed care for the better part of 11, 12 years. And one of the most frustrating things that I come across is talking to a particular hospital, and I'm talking to the utilization management person who may not know all the details, anything about the patient. They probably just saw the patient in the hallway or just went to treatment team. And the reviews were always the same review. It wasn't a person-centered review. Many questions that I would ask in regards to discharge planning or the titration of medication or family therapy, it was always, oh, that's a good question, let me call you back, or I just hear pages flipping over and over and over. It got to the point where our reviews would take like 25, 30 minutes for a certain hospital. On the other end of the phone, I was thinking to myself, if I ever work in the hospital, I'm just going to have the social worker do the review, because the social worker understands what the discharge plan is. They talk to the doctors, are part of the treatment team. They do the actual therapy with the patient. They talk to the support system, so they know all the answers already. So I actually did a pilot program while I was in managed care with a center called Hawthorne Center. It's a state facility, and they used their social worker as the review person, because we just got tired of talking to the utilization review person and getting the same information no matter what the patient was. And we found out that the reviews were so much better. Once I left the facility, I came here to Stonecrest Center, and I implemented a process where the social workers are now the utilization reviewers and are the discharge planners. They have the most intimate knowledge of all of our patients in regards to treatment, in regards to discharge planning, in regards to the utilization review, because the person on the other end at like a Molina or at a prepaid inpatient health plan, they know the person's utilization record. They know the past medications that worked for the patient. So they're able to gather that information and forward it to the physician as well as the treatment team. So that case management model was very successful with our hospital, and I'm sure it could be easily implemented in other hospitals as well. It just takes that whole social work utilization management piece and discharge planning piece all in one person. And our caseloads are generally 9 to 10 to 1, 9 or 10. Hopefully that answered your question.
Yes, it did. Thank you so much. I appreciate it.
Hi, Hi, Andrew. We also have a question from a participant. The question is, are you able to bill for the transportation services?
Okay. This is where I get myself in trouble. Okay, so I'm outside the box, all right? And I know that there's CFOs listening and financial people listening. This is how, and if this is not appropriate, then close your ears. So with the financial piece of it, it should be built in the contract. Now, we have PIHPs that are very local, within like 60 miles, and then we have PIHPs that are hundreds of miles away, Upper Peninsula, 400 or 500 miles. Now, keep in mind, if you're getting a referral from somewhere 300 miles away, how many hospitals are they passing by to get to yours? There's a reason why this individual is passing up 5, 6, 10 hospitals. Maybe it's a one-to-one issue, maybe it's a behavioral issue, or whatever it is. In your contract, that person most likely will have a higher length of stay due to the behaviors that are presented, due to the exacerbation of the person's illness, is going to yield, for us, I'm going to just talk about Michigan, a little over 15 days because of the acuity of the patient. Also keep in mind that since this person is 15 days and then your rate for that particular community mental health or PIHP program is generally going to be about another $75, $125 more than your average rate because they're coming from so far away. And so there is a reason why this person is here. So you're going to have a higher rate with a higher length of stay, which will make a smile on your CFO's face. And the transportation cost for us is only about $250 to go for 100 miles. So it's worth it in the long run in regards to financial, but the reason why we really do it is to ensure a safe and secure and by a trustworthy transportation service to make sure the person gets to where they're supposed to go. That's the reason why we do it, but it does financially make sense if you think about the higher length of stay and the higher rate. It's already really built into it.
All right, thank you. This is Carla. I do have a question. And as a former discharge planner myself, I wholeheartedly agree that the social worker working also at the UR and helping the patient is definitely critical, as you're better able to understand the patient needs as well as have a clear picture as to what appropriate placement would be for that patient. So yes, I agree with that. That was an issue that we had in planning and trying to get patients out in a timely manner. The question I have is that your contact person for your group home, I know for those difficult placements such as patients who are homeless and or without any income, that could be a huge barrier and increase the length of stay that they're at the facility. Is your contact person able to find a placement for your patient who may not have any income and are they able to get income for them as well as in a timely manner?
I'll address that, Carla. This is Andrew. Our placement liaison does, and I'll address the timeliness issue first. She does have a very quick turnaround. I've had situations where she's placed the person same day for us. She has good working relationships with her network of providers, and she will take someone knowing that income is pending, and we partner with several programs in our area that accelerate someone's movement through pursuit of Social Security income or other income, Social Security disability for that matter. So it's kind of providing this network of supports to the patient that will at least get them to that supportive setting so that they can continue to pursue the income, they can continue to pursue treatment, and that will encourage the provider themselves to then have the person within their group home or their assisted living or their room and board, whatever it may be. But it's taken time to build that relationship with the network provider as well as the homes themselves. They'll take them due to our good relationship. They know that we're going to set them up to succeed, and as long as they can keep the patient on track, they have nothing to worry about. Now, are there the exceptions with our population where it might not work out? Of course, but the providers themselves understand that and work with us in regards to our patients.
Thank you. Thank you for that. All right. Are there any other questions?
No, ma'am. There are no callers in queue for questions.
Well, okay. I guess we'll wrap it up. And gentlemen, you guys did a great job. You are doing some great things at working and engaging your patients over there, which is why we really wanted to catch you guys and showcase what you're doing. And have a chance to have people call in to see if they can possibly model, because you are doing some really creative things, and I love your strategies. So thank you again for your time and putting this great presentation together.
Thank you. Yeah, thank you so much.
And also the slides are also posted for those who want to pull the slides up for themselves. They are available on our website. All right. Thank you, everyone. We really appreciate you.
All right. I know.
Bye-bye. Thanks.
Thank you, ladies and gentlemen, for joining today's conference. You all may disconnect at this time.